Okay.
Start.
Yes, sir. Starting. Yeah. Good morning, all. At the outset, I thank Dr. Samuel sir, Dr. Gansham, and the Hicks for giving this platform to talk on this topic. So, why is echocardiography is important for us? It's because it helps you to evaluate a patient at the bedside. So, most important is you can diagnose the disease process early and you can initiate the appropriate treatment. So thus the patient gets the benefit of a shorter duration stay and its other advantages. So it is very important for all of us to own the skills of performing a bedside echocardiography. With basic echocardiography, you can identify pericardial effusion, pleural effusion, cardiac dysfunction, and many more valvular diseases. And if you apply advanced echocardiography, it also helps as a hemodynamic monitoring tool to assess fluid responsiveness. So basically what we want to know is what are the different movements of the probe. So the probe can be moved in a long axis. It can be moved in a short axis. Then you can slide or translate the probe on either sides along the long axis, along the long axis or the short axis, like this. So you can translate or slide the probe in this manner, or you can sweep or tilt the probe, or you can rotate the probe in either direction, either anti-clockwise or clockwise. This is just to get a good window, because in echo, what you're doing, you're trying to get through the intercostal space. Then you can tilt the probe. It is also called as fanning and sweeping or angulation, so that you try to get different cuts in the same plane. And then you can rock head to toe, that is in the longitudinal axis. You can do a head to heel to toe rocking, or it's called as a rocking. So all the and the compression, but anyhow, this doesn't apply to our echocardiography in the echocardiography. So these are the basic different movements of the probe. Then straight away coming to what are the normal windows for echocardiography. It is a tradition that we start off with an parasternal long axis view. Then we change to a parasternal short axis. Then we go to the apical 4-chamber. We do apical 5-chamber. Then the 2-chamber, 3-chamber, and the subcostal view. So how do we do a parasternal long axis view? So ideally, the patient has to be in the left lateral decubitus position, but which is not possible in our ICU setting. Most of the times, you may have to do an echo even while the patient is sitting. So the probe, the phased array probe, is placed at the 3rd or the 4th intercostal space, just lateral to the left sternal border. Then, why I say 3rd or 4th, it may be 5th also, because the anatomy of each person will change. So you have to just sweep or slide the probe to get an ideal view. But ideally, we say you should look at the 3rd or 4th intercostal space. Then the probe marker has to be pointed towards the right shoulder or at the 10 o'clock position. And the probe angle should be perpendicular to the chest. So this is how this diagram depicts how exactly we have to keep a probe. So the pointer is directed towards the right shoulder, and it is parasternal, and the axis is direction is towards the back. So this is what you are going to get with the parasternal long axis view. So the nearest structure what you are going to see is the RVOT, then the interventricular septum, the left ventricle, the mitral valve, the anterior mitral leaflet, and this is the posterior mitral leaflet, the left atrium, the aortic valve, and the aorta, and the LVOT. So this is what you are going to get in a parasternal long axis view. So so basically you will come to know regional wall motion abnormality. You can get to know the ejection fraction. You can get to know any pathologies of the mitral valve. So and even pathology of the aortic valve or dilatation of the aorta, ascending aorta. So you can get all these things. So when you put a M mode on this at the parasternal long axis, then what you get is an E wave and the A wave, similar to what you get when you do a for the diastolic dysfunction. So I'll tell the significance of this E and A of the mitral leaflet in the later slides. Next, we go to the parasternal short axis. So how do we get that view? So the most important thing is you should get an ideal plaques view before you go for the short axis. Once you get an ideal plaques view, you have to just turn the probe by 90 degrees. That means that the probe marker will be pointing towards the left shoulder, and the probe is tilted or swept. Once you get a short axis view, then the probe is either tilted or swept from the apex of the LV to the aortic wall to get different views in the short axis. So this is how the probe is oriented towards the left shoulder, and these are the different cuts you may get by just sweeping the probe from the apex to the aortic wall. This is another diagrammatic representation. So you have gotten a short axis view now. So when you cut the beam at the papillary level, this is the image you are going to get. This is the anterolateral papillary muscle, and this is a posterior-medial papillary muscle. And when you sweep it more towards the right shoulder, the next structure what you are going to cut is the mitral valve, which is called as the fish mouth appearance of the mitral valve. Then as you go still higher, then you get the aortic valve in the view. This aortic valve in the view. So an M mode is a motion mode. So whatever this line cuts can be seen as an image. So what is cutting, what the echo is cutting is first is the RV. So this is the RV what we are seeing. Then the aortic valve, which is in the center. Then the left atrium. This is the left atrium, and this is the left atrium. Then this is actually posterior to the aorta. That is the RA. And then you can see the pulmonary valve as well as the pulmonary artery. So this view of aorta, you can call it as a Mercedes-Benz view of the aortic valve. That is because of three cusps. So this is how in real time you get to see the papillary mid-papillary view. Okay. And the structures what you are going to see is the RV. So whenever you do a transthoracic echo, the most important structure, anterior structure you get is always the right ventricle. Okay, and then is the LV, which is contracting at the papillary level. So these are the papillary muscles. So it is again the regions of the LV is the septum. This is the septum, this is the anterior wall, this is the lateral wall, and this is the inferior wall. Okay, and if you put an M mode on this at the short axis view, then you will get an M mode tracing like this. And here also you can calculate the ejection fraction by something called as a fractional shortening method. As you move the probe towards the mitral valve, this is the fish mouth appearance of the mitral valve, what you are going to get. And this is the LV, good LV, which is seen contracting all over. So there's a good LV function here. And this is the RV. So in this view, we can see, calculate the mitral valve diameter, mitral valve diameter, and it helps you in assessing the mitral valve in mitral stenosis. So this is what you get to see in a parasternal short axis view at the mitral level. As you move the probe towards the right shoulder, this is the parasternal aortic valve view. As I said, you'll get a Mercedes-Benz sign because of the three cusps coming together. And this is the cusp which is near the RVOT is the right coronary cuff, which is near the LA is the left coronary cuff, and the one which is adjacent to the interatrial septum. Okay, this is the interatrial septum that is between the RA and LV is a non-coronary cuff. These things you have to know, and you can even see the tricuspid valve. You can see the pulmonary valve and the pulmonary artery. So many times in the case of pulmonary embolism, you can find clots sitting in the main pulmonary trunk. So this is how this view is also important. Another important thing what you can assess is for ASDs. So because you see the interatrial septum very nicely here, so you can see the ASD if you can put a color flow on the interatrial septum. Next, coming to the apical 4-chamber view. So here what you do is you place the probe over the left chest wall where you can feel the apical impulse of the heart at the best. Then what you can do is you can translate the probe around this area to view the 4 chambers. So what we do is we just place it at the expected apex of the heart. Then we move the probe like a dosa. So when you move that, there will be one place where you can get the ideal 4-chamber view, and then we stick to that. So this is how you have, because if you keep on just put it on the apical, you may not find it. So you should keep on sweeping and translate the probe to get the best view of the heart. Next, here the probe marker is pointed towards the left side of the wall. So if I'll show it in the next figure, and the probe to be directed to the interscapular area. Basically, I'm trying to tell it should be directed towards the back. So this is how the probe is placed near the apical area, the marker towards the left side, and the direction going towards the back. So this is what you are going to get with an apical 4-chamber view: the LV, the LA, then the mitral valve, the RA, and the RV, then the interventricular septum and the interatrial septum. So most of the structures are seen in the apical 4-chamber view. Here you can assess for the LV function, for the RV function, you can see RA-RV dilatation. Then if you use a color Doppler, you can see the mitral regurgitation or the stenosis, or the tricuspid regurgitation or the stenosis. So another structure what you will see here is a cross section of the descending aorta. So many times you can get to see the pulmonary veins entering the LA, or sometimes even you can see the coronary sinus which enters the RA in this view. Once you get the ideal apical 4-chamber view, what you have to do is you have to tilt the probe little bit towards the right shoulder to open up the aortic valve, which is seen as the 5th chamber. So the 5th chamber means the aortic valve and the aorta is seen in the 5 chambers. So the image is almost like a 4-chamber, but you have tilted the probe, and see, this is how you have opened up the aortic valve. And here actually you can see there is an aortic stenosis because the aortic valves are not moving independently. Okay, and what you do is here, if you can put an pulse wave Doppler at the LVOT, you can get an LVOT VTI. Or if you can put a continuous wave Doppler, you can see the gradient and the velocity across the aortic valve, which you have to, though it is a area of the cardiologist, but it is nothing wrong that you can also learn to do these things. So in the 5-chamber view, what extra thing you see from the 4-chamber view is the aortic valve and the starting of the ascending aorta. Next, once you get then once you see the aortic 4-chamber view, you have to go back to the aortic. Once you see the aortic 5-chamber view, you have to go back to the aortic 4-chamber view. Then you have to rotate the probe by about 70 to 90 degrees in the anti-clockwise direction to see the 2-chamber view, where you can see the LA and the LV. So you have got, this is the 4-chamber view, and then you have to rotate it anti-clockwise by 70 to 90 degrees. And this is what you are going to get. This is a 2-chamber. This is the LV, and this is the LA, and this is the mitral valve. Okay. So why this is important is if you want to look for regional wall motion abnormality in coronary artery disease, and if you want to know the area of the LV which is involved in the coronary disease, this will help you. So what you see is the anterior wall and the inferior wall in the 2-chamber view. And when you move the probe more clockwise from this 2-chamber view by 20 to 30 degrees, you will get a 3-chamber view, where again you can see the aortic valve and the ascending aorta. So this view resembles the parasternal long axis view. So this apical 3-chamber view is also called as the apical long axis view. So if you can recollect what I showed in the parasternal long axis, it's the same structures but at a different angle. So there you found it in the horizontal way like this, but here it is in the vertical. So this is the LA, this is the mitral valve, the anterior leaflet. The leaflet which is nearer to the aorta is the anteromitral leaflet. And then this is the LV, good contracting LV, the aortic valve and the aorta. So if you can make little alterations in the probe by sweeping, sometimes the RVOT also opens up. Next, coming to the subcostal view. So here the patient position should be supine, which is what we see normally in our ICUs. You should make the patient flex his hip and knees so that the abdominal wall is relaxed. Then the probe marker has to be placed on the left side. Then the probe is insinuated. This is little bit hurting to the patient because you have to press the probe under the epigastrium to look at the heart. So this is little uncomfortable for the patient. You should always, if a patient is awake conscious, you have to tell the patient that it is going to hurt a bit. And then what you have to do is you have to increase the depth setting to see the cardia, because it is on the little on the deeper aspect. And what you use here is you use the lever as the acoustic window. So this is how you insinuate the probe at the epigastrium and then direct it towards the left shoulder. Okay. So this is the view you are going to get. That is you are going to see the first you will see the lever here. Then the closest chamber which is seen is the RV. This is the RA. This is the tricuspid valve. This is the LV. This is the LA, and the here is a tricuspid valve. And this view is very helpful when you are resuscitating a patient, so that the CPR is not interrupted. Also, in this view, you can, if you are not getting good windows or post cardiac surgery, if there are dressings, so you can use a subcostal window. And also, this is the best window to see all the four chambers and the structures around the heart, that is a pericardium, especially to look for pericardial effusion and pericardial tamponade. So the subcostal view is included in both fast as well as fate. So this is another thing what you will see. Okay, the RV, the RA, LA, LV, and the LA. Then the suprasternal view, which we don't use commonly, what you do is you keep the probe at the suprasternal notch and direct it towards the heart. The marker should be pointing the cephalad, and what we see is this type of image. Okay, so you get to see the ascending aorta, the descending aorta, and the great vessels of the great vessels. So what when you do the suprasternal window, it cuts the right pulmonary artery horizontally. So this is the here you can see the right pulmonary artery. See the probe position is here. Okay, so this is you are getting a red one when you put a color dot. That way the blood is moving towards the probe. So this is the ascending aorta, and then this is the arch of the aorta, and then it leaves into the descending aorta and the great vessels. So this is how the suprasternal window, and here you can see for aneurysms of the aorta, or if there is a dissection of the aorta can be made out with this view. So next we come to how we apply this basic echocardiography for our assessment of ejection fraction. So ejection fraction can be assessed in by three methods with an echocardiography. You can use an MRI, you can use a CT2SS, but with the echo, we can do it by M mode, which is called as a T-close method, then the E-point septal separation method, and the biplanar or the Simpson's method. I'll be showing each method how you do. So basically, you have to get a plaque view. That is the bare minimum necessity. Then you put an M mode across the RV, then the interventricular septum, and just beyond the apex of the tip of the mitral valve. And this is the M mode. M mode is a motion mode, what you are going to get. So whatever structures come in this path will be seen in an 2D way. So this will be the RV, this will be the interventricular septum, this is the LV, and this is the posterior wall. So once you freeze that, you have to take the diameter at end diastole. So this is the end diastole. Okay, so you take the internal diameter of the LV at end diastole and internal diameter at the end systole. Then in most of the ultrasound machines calculate the EF the moment you put the two diameters. So basically what it does is it calculates by subtracting the end diastolic internal diameter by end systolic internal diameter divided by the end diastolic internal diameter, and you multiply by it by 100, then you get the ejection fraction. Okay, so the machine calculates for you. What you have to put is the end diastolic internal diameter and the end systolic LV internal diameter. The next thing, how we can calculate, this is another way to calculate, simple way of calculating the ejection fraction. May not accurately, but you can still always assess that the ejection fraction is good or normal or poor. So you have to put an M mode across the tip of the anterior mitral leaflet. Okay, this is the anterior mitral leaflet, and you have to put the M mode across the tip of the anterior mitral leaflet. And what you are going to get is, these are the two waves, the E wave and the A wave. This is the early ventricular filling or early atrial, early diastolic filling, and this is the filling because of the atrial contractions. So then what we do is we measure the distance between the tip of the E wave and the septum. So this is called as the E point septal separation. So if this is less than 7 millimeters, okay, so this is how the trace is done in the M mode. Okay, and if the this is the distance which has been calculated between the tip of the E wave and the interventricular septum. If it is less than 7 millimeters, that means that the ejection fraction is normal. If it is more than 10, then it means there is a low ejection fraction. So here the calculated one is 18 mm. So definitely this patient will be having a low ejection fraction. So this is E point septal separation. Next, coming to the biplanar method, that is the Simpson's method. Here what they do is, see, what we have done in the previous two calculation is we have taken a 2D measurement for a 3D structure. So you may not get an accurate ejection fraction if at all the patient is having an regional wall motion abnormality. In a 2D image, it is very difficult to calculate the ejection fraction. So what they have done is they have used this Simpson's method. What they presume is that the LV is made up of multiple cylinders. Okay, these are the multiple cylinders kept one over the other, and the volume of each cylinder is calculated. For that, what you have to do is, first you have to get the apical 4-chamber view. Okay, then you have to scroll the image so that you get the LV in diastole. So when you get an LV in diastole, then you start from the annulus, mark the inner surface of the endocardium to the other annulus. Then you say calculate. So this image is formed. So this is the volume that is calculated in diastole in the 4-chamber. Then similarly, what you do, you scroll the image to get a diastolic view, and you do the same thing, and you get a volume of the LV in diastole in 4-chamber. Then what you do is you do a 2-chamber view, and you repeat the procedure what you have done before, the steps what you have done before. So in diastole you see the volume, and in the systole you see the volume, and then the echo machine, the ultrasound machine, will automatically calculate the ejection fraction. So this is the most preferred method because you are calculating in both the dimensions. It is in a 3D way you are calculating. So this is the most preferred way, but it is quite tedious and it is time consuming. For our bedside, I think the EPSS and the IM mode is more than enough. So this is the same image of the calculation of the Simpson's method. So next, coming to the TAPSE. So this will, the TAPSE will help you to look for the, assess the right ventricular systolic function. Right, the left ventricle, it contracts in a concentric way. Okay, because the muscles are arranged in a concentric way. If you see the right ventricle, it contracts in the longitudinal direction. Okay, So this is the difference between the LV and the RV contractions. So what you do in the image on this side, you can see that the RV is dilated, and what you see is the free wall of the RV is not moving that much. Okay. So what you do is you put a M mode on the lateral mitral annulus, of the tricuspid valve, and then get this tracing. So once you get this tracing, what you do is the peak of the graph and the trough of the whatever image you are getting, you have to see the distance between the two, and that is the tricuspid annular plane systolic excursion. So this will help you to see whether the right ventricular systolic function is good or bad. If the TAPSE is less than 17, then you can say that there is a right ventricular dysfunction. And in chronic heart failure, if the TAPSE is less than 14, that means that it has got a very poor prognosis. So this is how you calculate the tricuspid annular plane systolic excursion to know the RV systolic function. Then we'll see just the common pathologies which we see in our ICUs. So this is the normal short axis view at the papillary level. Okay, parasternal short axis at the papillary level, and you can see how nicely the papillary muscles are distanced. But in this frame, you can see the papillary muscles are kissing. So I'll show you another this one. So this is an empty LV, and the papillary muscles are kissing. So even in the long axis, you can see a empty left ventricle. Here we don't say papillary muscles are kissing. Here you say there is a LV is empty, but here it is the kissing papillary muscle. This is the image I took just 2 weeks back. This patient was shifted from another hospital, telling that the patient is in hypotension with almost 10 ml per hour single strength adrenaline going. So how can you expect the BP to improve when the tank and the tubes are empty? So basically we have to give if you increase the pump with the noradrenaline, it's not going to help unless there is unless the tank is full. Okay, so this is how a bedside echocardiography will definitely help you people to assess the fluid status of the patient. This is a 4-chamber view where you see a global LV dysfunction. Okay, so you can see the whole LV is, it may be some cardiomyopathy secondary to viral or whatever conditions we see. It is a severe LV dysfunction, and we have calculated the ejection fraction, and definitely you are going to get the less ejection fraction. And here, though I am not sure, it is not in the parasternal long axis, you can see that the mitral wall is not going too near to the septum. So that means that the EPSS also will be more, and it will indicate that there is a poor ejection fraction. Then coming to the Takotsubo cardiomyopathy or stress cardiomyopathy, here what will happen? There will be an apical ballooning because of sudden surge of catecholamines. So the basal segments will be contracting well, as seen here, whereas the mid and the apical segments will be akinetic. So this resembles the Japanese octopus spot, so it is called as the Takotsubo cardiomyopathy. Then the regional wall motion abnormality, which we have to know very well. So, so each coronary artery has got a area that it supplies. So the lateral wall of the RV, then the basal septum is supplied by the RCA. Then this is the inferior wall, which is supplied by the RCA. This purple color is the area of supply of the LAD. Okay. This is the anterior wall, this is the apex, and this is the apical septum. Similarly, and even in the short axis view, you can see the regional wall motion abnormality. So usually what the most comfortable is, if you can get a good mid papillary view, you can see all the 3 vessel areas which can be supplied, and it can make out the regional wall motion abnormality. So some examples, this is an anterior wall MI. The LAD territory, what you can see is there is akinesia here in the septum and even in the anterior wall. The images are not that good, but this is a 2-chamber view where you can see the inferior wall is contracting very well, whereas the anterior wall is not contracting that well. And here also the mid and apical septums are not contracting well. So this is the junction between the circumflex and the LAD territory, and you can see an hinging of the LV wall there. Then this is a circumflex. See here, the lateral wall is not moving. There is a regional wall abnormal to the lateral wall, and similarly here, this anterior is septum is moving and the inferior moving, but the lateral wall is not moving. So that is the LCX territory, and this is the inferior wall. So you can see good LV contractions of the septum and the lateral wall, whereas the inferior wall is not moving. So this is the RCA territory. Then coming to what you see in a pulmonary, what are the echo findings in acute pulmonary thromboembolism? So the main thing is the dilated RA and RV, okay, in the 4-chamber view. And what you can appreciate is, so you can appreciate tachycardia also in this echo, isn't it? Dilated RA, RV. And here you can see the mecanal sign. So the apex is contracting, okay? The apex of the RV is contracting, but the free wall is not contracting. So that is the mecanal sign. And if you see, usually in the 4-chamber, the apex is always formed by the left ventricle, isn't it? But here, because of the dilated RV, the RV is coming almost to the apex. So this is another sign that the RV is dilated. And in the parasternal short axis view, what you can see is the D-shaped septum. That is because of the pressure overload on the right side. The ventricle, the left ventricle is been compressed, and you see the D-shaped septum, D-shaped left ventricle, and a dilated RV. So the RV sits like a golf cap on the left ventricle. Then the severity, to know whether this RA-RV dilatation is acute or severe, acute or chronic, what you have to do is you have to see for the tricuspid regurgitant jet. So you have to calculate the pulmonary artery pressure. So what you do is you in the 4-chamber view, you get a good view of the tricuspid valve. Then you put a color, so you can see a lot of aliasing there. Then you put a continuous wave Doppler here. The moment you put a continuous wave Doppler and enable it, you get some these type of tracing. This is the regurgitant jet. So what you have to do, you have to calculate the TR max, the tricuspid regurgitation maximum, and you have to square that and multiply it by 4. You will get the pulmonary artery pressure. So if the pulmonary artery pressure is less than 25, it is normal. If it is between 25 to 40, it is mild pulmonary artery hypertension. And if it is between 41 to 55, it is moderate, and more than 55, it is severe. So what you have to know, how you have to differentiate whether it was the RA dilatation or the pulmonary hypertension is acute or chronic is, if the pulmonary artery the pressures are above 55, then invariably the pulmonary artery hypertension is chronic, because when the pulmonary embolism happens, there is very less time for the RV to hypertrophy. It takes at least 48 to 72 hours for the RV to hypertrophy to cause that much of pulmonary artery pressure. So if the pulmonary artery pressure is 40 or 55, then you can think that it is an acute pulmonary raise in pulmonary artery pressure. But chronic, like something like 80 or 90 of systolic pulmonary artery systolic pressure, will be it will be a chronic cause. So again, I'm telling the same thing. So this is how you calculate. You get a 4-chamber view, then a tricuspid jet, then you put a continuous wave Doppler, you get a peak, TR jet peak, then 4 times the peak, plus you have to add the CVP to get the pulmonary artery systolic pressure. So you do an IVC and see for the collapsibility, and we all know what will be the CVP at different diameters and collapsibility. You add to that, then you'll get a pulmonary artery systolic pressure. Then this is the parasternal long axis view, where you see the doming of the anterior mitral leaflet. This is very classical of mitral stenosis. It is also called as the hockey stick appearance of the anterior mitral leaflet, and you can see the mitral valve in diameter is so small. Okay, and here you get a lot of aliasing, means that the blood is moving with lot of turbulence. So you can make out the mitral stenosis with the long axis and as well as the 4-chamber. Then the mitral regurgitation, what you do is you put a color Doppler at the mitral valve, and if you are getting the flow more towards the away from the probe, that is the mitral regurgitation. Okay. Then these are few conditions where the thrombus is sitting in different places. So this view is the aortic valve view or the wraparound view. Why they call the wraparound view? This is the short axis, parallel short axis aortic valve view. The aortic valve is in the center. The LA is here. The RA is here. The RV, the RVOT, the pulmonary valve also you can see moving, and the pulmonary artery is dilated, and you can see the clot. So this is the pulmonary embolism clot. Okay. Then you can see a clot in the RV here. Then the clot in the LA. Then probably this is a case of MI where the anterior MI where the apex is not contracting, and here in the left ventricular apex there is an LV clot. Then this is a subcostal view, and what you classically see is a pericardial effusion, the swinging of the heart. A patient with so much of pericardial effusion can still be stable. I'll tell why in the next slide. So this is called as a swinging of the heart. Dr. Saikath has been putting a lot of echoes, and this was one of the echoes recently. Okay. So here also there is an effusion, but here we are calling it as a cardiac tamponade because you are seeing the diastolic collapse of the RV. So if you see the diastolic collapse of the RV, that means that the RV is not getting filled. So the preload is less, and that then naturally the preload of the LV also will decrease. And this scenario is a tamponade. It's an obstructive shock. And the speed of collection of the pericardial fluid, be it blood or that is more important. So a patient who is having 3 to 400 ml of pericardial fluid may be very stable, but 50 to 100 ml of pericardial fluid in an acute phase is enough to cause a cardiac tamponade. Then this is again a parasternal long axis view where you can see a dilated ascending aorta and aortic aorta with the dissection. So this is the dissection intimal flap. So this is how you can make. If you can put a color Doppler here, definitely you can see aortic regurgitation. So this is ascending aorta dissection. Then left ventricular hypertrophy can be seen. There is a normally the thickness of the LV changes from the base to the apex. It is around 1 to 1.2 centimeters. So you have to see the thickness of the LV and comment on the left ventricular hypertrophy. So this is a left ventricular hypertrophy, what you are seeing in a hypertension, such scenarios. Okay, then next coming to the hypertrophic obstructive cardiomyopathy, where the LV is very thickened. Okay, the LV is thickened, and what is happening is the tip of the mitral valve is going and abutting against the septum. So this is called as a systolic anterior motion abnormality in an hypertrophic LV, and this will cause LVOT obstruction. So we have to appreciate this feature whenever you see a hypertrophic LV. Then we see vegetations in infective endocarditis. This is the 4-chamber view where you are seeing the vegetations in the tricuspid valve. Here you are seeing vegetation in the mitral valve. These are a few cases where there is a left atrial myxoma, which is moving across the LA-LV. Okay, this is a left atrial myxoma. You can see in this view that it is attached to the intra-atrial septum, and it is trying to go into the LV and coming back to the LA. So one of the mechanical complications of MI, if the patient has got an anteroseptal MI, he improves and suddenly deteriorates in the ward of the 3rd or the 4th day. So here the cause is probably a mechanical complication. It can be a free wall rupture or a ventricular septal rupture. But make it a point always to auscultate the patient before you keep a probe, because it is very easy to miss small mechanical complication. New murmur should always alert you that some mechanical complications have happened. Then you apply a color probe, and this is what you are going to see. There is a rent in the LV septal intraventricular septum, and this is a ventricular septal rupture. Then coming to the diastolic dysfunction, one of the causes for pulmonary edema and breathlessness. So what you do is you get a good 4-chamber view, and at the mitral valve inlet inflow place, you keep a pulse wave Doppler, and you get a E wave and a A wave. So what we do is the moment we calculate the E wave and the A wave, the machine will calculate the E by A ratio, and the normal E by A ratio is 1:1.5. If it is less than 1, that means it is a grade 1 diastolic dysfunction. This is because of impaired relaxation. Then you have to also see the deceleration time. This is the deceleration time. This is a separate task by itself. So usually it is more than 160 milliseconds. So if the deceleration time is more than 200 with the E by A ratio of less than 1, then it is grade 1 diastolic dysfunction. Similarly, these are the different grades of diastolic dysfunction. So the E by A ratio is more than 2 is reversible restricted grade 3, and this is the fixed restricted. This is an irreversible stage of the diastolic dysfunction. Next, how do we calculate the cardiac output using a LVOT OTI? So basically, you use this formula of pi r square h to calculate the volume. So what is a pi r square? That is the aortic valve diameter or the LVOT diameter. And what is h? H is the volume of blood that is pumped into the ascending aorta. So the height, this height can be calculated using the LVOT VTI, and the pi r square can be calculated by calculating the diameter. So what you do is, first you get an proper parasternal long axis view, okay, and then you zoom the LVOT. Once you zoom the LVOT, you have to calculate the distance between the septum and the aortic valve annulus on either side, okay, and at diastole, okay, at the systole, when the valves are totally open, okay, when the valves are totally open, you have to calculate the diameter of the LVOT. So that is the diameter. So you halve it to make it a radius and use it for and calculate by pi r square to get the diameter. So here the diameter is about 2.3 centimeters, okay, and then after getting the diameter, which will remain constant, you have to see go for the 5-chamber view. Then you have to keep a pulse wave at the LVOT. Once you keep the pulse wave and activate the pulse wave Doppler, so you get something called the LVOT VTI, and you have to trace the LVOT VTI. So you have to take 2 to 3 pulse wave Doppler LVOT VTI and then average it. So this is what they have done. They have taken 3 values and they have averaged. So next is, so this value came as the aortic area came as LVOT area came as 4.15 and the VTI came as 13 centimeters. So if you multiply the two, you get the stroke volume, which is 54 ml. So this is how we calculate the stroke volume using the LVOT VTI. Then that multiplied by heart rate will give you the cardiac output. So this is the use of echo in calculating the cardiac output. So you can use the stroke volume variation during a PLR for fluid responsiveness also. So what you do, you keep the patient in 45 degrees, okay, then you calculate the aortic valve diameter, then you see the VTI, LVOT VTI. Then what you do, you make the leg raise, and then you calculate the VTI again. So you have to calculate the stroke volume with the VTI in the 45 degrees and when the legs are raised. So you get a maximum stroke volume and the minimum stroke volume by calculation divided by mean. So you will get the stroke volume variation, which is 12. If it is more than 12%, that means that the patient is fluid responsive. But you have to be very fast in calculating that, because you get only 1 minute time to calculate the LVOT VTI. But no harm in practicing, and once you practice, you are definitely going to get. And why you need very expensive hemodynamic monitors when you can do it at the bedside with an echocardiography. Similarly, you can use a LVOT VTI also to measure the fluid responsiveness. So you calculate the maximum LVOT VTI, the minimum and the mean, and you multiply it by 100, then you will get a change in LVOT VTI. Okay, so you calculate the maximum here, the maximum is there and minimum is there. That so using this formula you can calculate, and if the LVOT VTI change in LVOT VTI is more than 20%, that means that the patient is fluid responsive. So I end my session with this. Hopefully I have cleared most of your doubts. What I want to say is that echo is a skill what you have to own on you can't depend on a cardiologist coming at the midnight, because so many scenarios, the patient is sent as different scenarios. Only when you know what you only have to see to believe it. Okay. So thank you, sir. And my talk.
Thank you, Guru. I think it was an excellent tutorial on what to do and how to get the windows and how to actually assess the cardiac function. So it is now become an integral part of ICU assessment that we assess the cardiac function also. Not only that, it has become a part of the integrated extended ultrasound approach to patients who are hypoxic. Two areas where ultrasound plays an important role is hypoxia and shock, where lung and cardiac assessment are integral parts of your clinical assessment as well. So knowing how to look at the heart is now a essential clinical tool for most intensivists, not only from a hemodynamic point of view, but now the entire focus of mechanical ventilation has added. Previously, we were only looking at lung protective ventilatory strategy and diaphragm protective ventilatory strategy. Now, safe mechanical ventilation focuses on right ventricular protecting ventilatory strategies, and that strategy is actually based on how your driving pressures and your lung compliance affect your tricuspid annular plane systolic extension. How much of RV dysfunction does our upstream obstruction to RV outflow produced during mechanical ventilation is an integral part. So knowing how to acquire these windows and get the correct measurement is the important aspect. Right ventricle, if you remember, any assessment of hemodynamics begins with the assessment of the right ventricle. And we try to optimize the functioning of the right ventricle by improving the intravascular volume. So the behavior of the right ventricle to interventions is the key to an improved stroke volume, which is a function of the left ventricle. So we do very few interventions in general intensive care to improve the function of the left ventricle. We only increase the afterload by giving vasopressors. Whereas here we have the option of dragging out fluid, adding fluid, decreasing pulmonary vascular resistance. So many options are available to improve the forward flow from the right heart. So assessment of the right heart is also an integral part. So a comprehensive knowledge of integrating lung ultrasound, diaphragmatic ultrasound, and cardiac ultrasound or echo, in other words, is a very useful and informative tool for somebody who is looking after critically ill patients. Sometimes we may not be in critically ill patients who are on mechanical ventilation and are immobile. It may not be you may not be able to get the classical apical views, especially the 5-chamber and the 4-chamber views. But the parasternal long and short and the subcostal views are very informative from a critical care perspective, and we should try to get hold of a machine and try to practice it in as many patients as you can if you want to improve your skill. So we will extend this discussion next week to the importance of the right ventricle and how the right ventricular performance and assessment and function has implications for intensive care. And I will be doing that discussion. Please do join us. Those of you who have any comments or queries on today's lecture, may please post those queries on the group on which you got the link to attend this webinar. Thank you for joining us. Please do join us next week, and please do subscribe to the Hicks YouTube channel, where all these videos are actually uploaded and are running for you to revise, especially this one. It's not enough if you listen to this kind of a talk once. You need to keep listening to it, looking at the pictures, the windows, the pro position for you to improve. So please do join us again next week. Till then, bye-bye and have a good day.
Thank you, sir.